Sounds good. Okay, so I think we will go ahead and get started. So thank you everyone for joining us. My name is Maria Walker. I'm the Vice President of the Scleral Lens Education Society. So just briefly before we get started, just remind you of our fellowship program. So this during COVID-19 is a great opportunity to get those fellowship applications finished up and sent to us. So you can go to our website. No cost for membership. And then if you are interested in becoming a fellow, we encourage you to explore that option. Today, we're going to hear from 3 of our fellows about telemedicine. And of course, the reason for these new webinar series is with all the craziness going on with COVID-19. Here you see we do have a Scleral Lens Society webpage dedicated to COVID-19 information. This webinar is going to be recorded and archived, and we will have this up on our website. So I will go ahead and introduce our panelists from today, and then they will take over. Again, like I said, they're all fellows of the Scleral Lens Education Society. So John Gels, who is up in Teaneck, New Jersey, he graduated from Pennsylvania College of Optometry, and he now is the director of Specialty Contact Lens Division at the Cornea and Laser Eye Institute in Teaneck, New Jersey. So he's really pioneered the use of telemedicine even before COVID-19. He was very involved in developing these systems. So he's going to share with us kind of how telemedicine can be integrated into scleral lens practice. Along with him, you'll hear from Dr. Marcus Noyes. He was a graduate of the University of Houston College of Optometry, is currently a clinical assistant professor at the University of Iowa Hospitals and Clinics. They see a massive volume of specialty scleral lens patients, so really, really sick eyes. He's been handling their telemedicine and is going to share his perspective along with John. And then we'll hear from our third panelist. Probably needs very little introduction, but Dr. Clarke Newman. He's up in Dallas, Texas at that Plaza Vision Center. He also graduated from the University of Houston. He actually is one of our externship sites, and so I know it's a very coveted contact lens specialty position up there. He's kind of the guy to go to for billing and coding with specialty contact lenses, and he is going to share how billing and coding can be integrated in. So feel free to ask questions throughout using the question and answer or the chat feature. We're going to start from hearing from John and Marcus, so I will let them go ahead and get started.
Perfect. Well, thank you very much for the introduction, Maria.
Yes, thank you.
Marcus. Shall we get started here? So essentially, one of the questions that we constantly get asked about telemedicine is what can you really do with it and what's its application in specialty contact lenses. So there are some pros here of what you can do. And generally it's that, we're able to do gross analysis, and that gross analysis can allow us to, make moderate changes to haptics, and to take a look at kind of, the ocular surface. The downside is that we are really reliant on the patient to be able to give us the types of images. Marcus, when you see pictures like this, do you get these quite often from the patients sending in the telemedicine images?
Yeah, we do. A lot of the times, which understandably, the patient pulls out their phone, right, first step, and then they put on their selfie camera because they're taking a selfie, hold it as close to their eye as they possibly can, to make sure we can see okay. And then you get an image where obviously you can tell there's an eye there, but not much else.
Yes, exactly. So, really when we had this initially, this had been a problem since about 2017. And, we tried to find a way to solve this issue. And the way that we do it is we send extraordinarily comprehensive instructions beforehand. Essentially what these instructions are going to tell an individual is, how to properly align an image to be able to take it yourself. We include how to do it, photos, videos, and then some examples of what we need. Marcus, are you guys doing about the same at Iowa?
Yeah, so I actually, it's funny, had been working on some sort of instructions to try and help. And then you sent me, or I think you posted online somewhere, your instructions that you have listed here. And I was like, this is 3 times as detailed and already done. So I might be borrowing a couple of those points.
Yeah. We're happy to provide this to everybody who's online right now. Essentially, what we're doing with this is we're kind of teaching an individual how to do it. I can actually demonstrate it right now because I can look into my my camera right there and see myself going on here. So essentially, what you're going to do is go ahead and open up your phone, and then from there, what you can do is take your zoom and put it up to 2.5. What you're then going to do is go ahead and change your flash so that it's on, not on auto, but rather on. If you're holding, the phone with your right hand, you're going to take an image of your right eye. And what you're going to do is just line that up just like that. Make sure that it's in the right position, open wide, and then go ahead and take that image. Now,
John, you have them do that in front of the mirror, correct?
Yes. Now, if they have somebody else there that's capable of taking the image for them, doing that is just fine. But typically, we have them do that in front of the mirror. Now, when I'm holding that that device away from my eye, I'm typically about 3 to 4 inches away, and this digital zoom is what's taking care of it. I found it, and Marcus, you found the same. If you don't have the digital zoom on, they're trying to get it to the to the focal point where it's like at its clearest, and they're bringing it all the way up to the eye and all these other things. End up with a really blurry, awful image.
Yeah, that's probably the biggest troubleshooting step that I've had is tell the patient, pull the phone away from your eye and then zoom in on the digital zoom to get a better image.
Yeah, now this I'm going to go ahead and try and share a little bit with you guys, but you can see that was that image that I just took, and you can see the blood vessels present. You can see just about everything on that cornea, and you get a nice gross detail of the eye with that. Now, these are some examples of kind of what we got with and without instructions. You can see this individual, this is their first attempt with it on the left there, and then a second attempt once they receive the instructions. And again, we got another example here. You can see clearly, again, what the difference is between the two, and it's quite stark. This can also be used for video. The great part about the video, let's see if that's in, yeah, it is. Okay. You can get a full, analysis of the eye and kind of how it's moving, how everything's moving on the eye. The real big limitation with this is that, with these images, you're really only getting a diffuse white light view of the eye, and you're not able to really appreciate any sort of depth on the eye because you're not having any sort of binocularity, and you're not able to get any sort of slit out of it to be able to really check that. Now, Marcus, when you look at this, are you finding pretty much the same thing?
Yeah, exactly. In terms of scleral specifically, there is some stuff that I was actually surprised that I could tell. And I think even looking at the pictures that you included in your slides there, it borderline rivals anterior seg photo sometimes, just using the patient's own phone. So things like blanching or compression, which looks like you saw where I was going with this, pulled up a nice little picture. You can tell that pretty clearly. Things that you don't need depth for, you can do a surprisingly good job at assessing with just the cell phone camera.
Yeah, one other trick that I've used with a patient who was describing symptoms of what sounded to me like a corneal ulcer that I couldn't see even in a decent photograph was I had her take a flashlight and shine it from the side.
Yes.
And transilluminate the cornea, and I saw the ulcer easily and brought her in. So
yeah,
you can do that as well.
Yeah, there's a whole bunch of tricks, and as we go through this and people become more and more comfortable with it, I think we're going to find, like what Clarke was saying, we're going to see that there are different techniques that we can have individuals take on. The other thing that's going to get really interesting too is as the cameras evolve, we're going to get more and more depth out of it. Right now, the problem with these cameras is, you have two cameras that have two different set focal distances on them. So even though you would have the possibility of creating some binocularity to it, the set offset in the foci is going to cause some issues. Now, there was one camera that came out that did have two cameras, one on either side, same focus, and it was made with the express purpose of creating a holographic image for the display. The problem was that that phone was about $2,500 and just flat out didn't catch on. But it made for an interesting play. Now, this image set here is actually to make a really important point, is that even with what may be considered kind of crummy photos, if the megapixels on the camera is high enough, you can zoom in and still get a tremendous amount of detail out of the image. So this is clearly the same image here. All we did was just zoom in on it, and we're able to see much more detail there than what we had before. But today, when I first started working on telemedicine for eyes, it was 2015. And the devices that we had about 5 megapixel back cameras and about 2 megapixel front cameras. And with that, you just really weren't able to get any sort of detail that was allowing you to make any sort of diagnosis other than there's an eye there and it's white or it's red. And, what we started looking at was how can we best image this eye and exploit the higher megapixel camera. And that's where we had to come up with the idea of kind of, shooting the back side of the camera towards the eye rather than the front camera towards the eye. Now, Marcus, when you're going through this, and Clarke, you too, have you found that, if you have a patient and they send you images and they may have, I don't know, an iPhone 6 or like a, something to that extent where the phone is clearly older, are you able to get any sort of idea as to what's going on with the eye? And do you just tell them immediately, look, I can't do anything with this, you got to come in?
I think part of that depends on the patient's history and what's going on, not just the picture itself. I've had a lot of patients just in the past couple weeks since COVID and everything send me pictures of an exactly normal looking eye. And they're like, well, it's kind of itchy. I'm like, okay, so even though you took it with the original iPhone, I can tell that your eye is white. Probably don't need to come in for this one. We can try doing things like antihistamine drops or, some allergy related treatment. And then I'll say, if things get worse, please send another picture, or you have to come in if things get worse. But I think you still can get some information. Obviously, I'd prefer to have pictures like the ones you have in your slides here, but you can get some info from the older stuff too.
Yeah. Clarke, how about you?
Well, I mean, one of the things that I've noticed is that we have had an uptick in contact lens complications because patients are varying their wearing schedules so much that they're adapting and de-adapting, and we know how troubling adaptation is because that's when most of our contact lens complications occur. So I really am paying very close attention to the history before we look at imaging. I mean, a good part of telehealth is talking to the patient and being, certainly relying on images, but again, it's not the number one thing that I do. It's mainly, and it's probably more important in this environment to do a very, very controlled and organized case history, because you get most of your answers from that.
100%. I think, really what this has done for me has made me have to improve my, historian skills, I didn't realize, because most of the time the techs are working them up. I'm only checking a history if something's not making sense or not adding up. But, from this point, I'm doing the entire thing front to back, and I'm finding that a lot of the things that are coming up, just by listening to what they're having to say, I can say, pretty definitely that this is, going to be a disaster, going to be okay. And, typically is this allergies, is this dry eye, is this, an abrasion, something I need to worry about. You get a pretty good idea of what's going on even before you see the individual. Now, the other thing that I wanted to ask you guys, now, obviously what we're showing here are all the pictures, which are kind of an asynchronous way of communication with a asynchronous communication with the patient. So they're sending you that, you're evaluating it. Are you every single time doing a video chat or a synchronous communication after that?
Absolutely, because if you want to code and bill for it, and we'll talk about this later, is that they currently have to be, you have to have, except when you're talking peer-to-peer, they have to be synchronous. They cannot be, now what we're talking about when we're talking about synchronous versus asynchronous, probably need to define that. A synchronous evaluation is a real-time thing. If you take a video or a photo and store it and send it, and the doctor looks at it later, that's considered asynchronous telehealth. And all of the codes, as you'll see later when we're talking about coding and billing, they're all for synchronous interactions except for the peer-to-peer. So I always talk to the patient because I can't bill for it if I don't.
Yes. Marcus, what about you?
Same. Nothing really there to add.
Okay. Yeah. For me, the other thing that has helped, because I've gotten some history and other things where the patient says I'm in pain. And I really love having the video consultation because I can actually see what level of pain they're in. Mm-hmm. Actually being able to see the body language of the patient, I didn't realize how incredibly important that is. But, for those individuals that may be complaining of pain, and when I, go to video chat them, they're in a bright room, they have no, signs of irritation, they're talking with me like they're just having a chat, that individual is not in pain. Now, the individual that I get that says I'm in pain, and when I communicate with them, they're in a dark room, they got the sunglasses on, they're winced up and kind of eye closed, right away that is an individual that has to be in the office.
Absolutely. I think everybody's had that patient where you get a message that they're in the worst pain they've ever been in, and they come into the room and they're smiling. Hey, doc, how's it going?
Yeah, exactly.
So yeah, I think it's really important to get the body language aspect of that.
Yeah, great litmus test.
John and Marcus, there are two questions that have been asked.
Oh, yes.
That we probably ought to address here. One comes from Artie Shaw that says, do these pictures still come out well enough for those who have older phones with just one lens? And I guess you might want to address that.
So I'll go ahead and take that one. So essentially, it really is dependent on the ability of the phone to do a digital zoom. Now, you don't need a actual zoom function on the phone. There are very few phones that have a real zoom function on them.
And that was Shelley Cutler's question. How do you know a patient has a zoom feature on their phone?
Yeah, so you don't have to worry about if they have a true zoom on the phone. What we're talking about when we say zoom is a digital zoom, and every phone that's been made since 2014 has a digital zoom on it. Essentially what a digital zoom is versus an optical zoom is the digital zoom is zooming in on the megapixels versus the optical zoom, which is actually using the foci of the lens to be able to adjust the magnification. Now, I think some of the new Samsungs have the ability to do a real optical zoom, and I can't remember which version it was of the iPhone, but it also has a true zoom capability as well, and that may be expanded on with the new 12 that's coming out. But generally, though, I found that most individuals who had megapixels under 8 megapixels, I was not able to get quality enough images to be able to, with any sort of good detail, be able to see what's happening. But pretty much everything from 2017 forward it is certainly adequate for taking images of the eye.
So one of the things I'm going to jump in and address really quickly, because it'll come up later in coding and billing, is that there are certain types of these platforms that are approved to be used under the HIPAA laws, because it's not just the billing laws. They have to comply from a privacy standpoint. And right now, a cell phone, as long as you're not publicly facing the information that you're gathering, is an approved communication for Medicare and Medicaid. That will not be the case when the waiver goes out. And so a phone won't be a secure method of image transfer when the COVID emergency goes away. So we're using cameras right now on our phones as an expediency that will not be available to us once the pandemic goes away.
Let me just clarify one thing on there quick. Yeah, everything that Clarke said was right on. The HIPAA is not being enforced, so you can use your phone. You can actually use any video service right now, I believe, as long as, like you said, it's not public facing. So what that means is, as long as you're not posting it on Instagram Live or Facebook Live or anything that's open to the public, in the short term, you should be able to use it for telemedicine, but that's definitely going to go away once we get this COVID thing more under control.
So I want to go ahead and just jump in real quick to things that you can go, well, what can you see? So in this image, I mean, clearly I labeled it on top, unfortunately, but the thing that you could see here, you can actually see this individual's LASIK flap. When I go ahead and put this image up and I remove it, you're going to be able to see that he has a nasally hinged LASIK flap that's present. And the details of these phones these days, it's quite incredible. Now that's really easy to see on a light eye. Now when the eye gets more pigmented, it becomes more and more difficult. So this is an individual here who has a transplant. This individual, this was last Friday's telemedicine. This individual had called me saying that he had some redness and irritation of his eye. That is another important thing to say, is that I'm doing this with established patients. I'm not doing this with Joe Schmo off the street. I have histories. I know what these individuals have gone through. I know that this individual is status post penetrating keratoplasty, and you can actually see his keratoplasty here. And what you can also see is some corneal opacity that's there as well. Now, as we go forward on this, I went ahead, I check out the rest of the eye, and you can see that he's got about a grade, 1+2 bulbar injection here. And you can see again, another graft host junction image there. But again, you can see it's kind of diffuse everywhere. Now, when we went into the history a little bit more, he was complaining of itchiness and irritation, all those sorts of things. But being that he does have a transplant, I did start him on an antibiotic and a light steroid, but I was going to see him the very next day in the office. These are the sorts of patients where, some individuals, and I'd ask both Clarke and Marcus, on an individual like this, I'm treating to my comfort level. So I may initiate treatment on this, but I'm certainly not going to say, hey, let's follow back up in a week. For me, with a patient that's got a, high risk sort of, well, not super high risk, but a higher risk of an issue here, I'm going to see them in the office just to ensure that things are okay and that this isn't like the early signs of a graft rejection, because these cameras, frankly, are not quite good enough to see fine cell and flare, fine KP, although they can see actually very well heavy KP. We did have that this morning, but
yeah, I think that's an excellent point, John. One of the really good uses for telemedicine is almost like a bridge between visits. So like, for example, I have this one patient that he's the one that calls every single day, but it's like the same problem. My eyes hurt. He's a graft versus host patient. calls me every day. And using telemedicine, real quick, he is wheelchair bound, and he lives 6 hours away from the clinic. The only way that he can make it in is if he can get someone that he knows to take work off, to take him to the clinic, and then it's a whole day ordeal. So it's a big deal for him to have to come into the clinic. So I'm able to see pictures of his eyes and things like this, and maybe start him on a steroid to get him past a week or so until he can get someone to bring him in for his next visit and look at it. Another use for it could be like weekends or things, you know, if someone can't come in until the next week, you can start telemedicine, start them on treatment to your comfort level, but still have them come in as soon as it's possible that they can.
So the only thing I would add to that is that the AOA and both academies, as well as the American Association of Telehealth, all have policies regarding telehealth. And one of the tenets that's common across all of them is that the care delivered using telehealth must meet the standard of care. And the standard of care is what a prudent doctor similar to yourself would do under similar circumstances. And you know, if the average doc would start a treatment plan and then see him back the next day instead of the next week, now the case that Marcus just alluded to, I think that's a special case. But in this type of situation, you probably need to make sure that you're adhering to the standard of care. And if you're unsure, ask a few colleagues what you should be doing. And I think in these situations, it's a balance between putting the patient at risk by going out in public versus the risk of mismanagement of the eye disease. And I would be more cautious than I normally would under other circumstances.
Absolutely. Yes. Great clarification.
Yeah. Now, one thing that I wanted to add to that was essentially that right now and going forward into the future, but specifically right now, I think the important portion of this is to provide a telemedicine solution during this time for patients that would have an emergency or urgent situation. The reason being is, you know, when we look at the number of, you know, red eyes that show up in emergency rooms that end up being, you know, subconjunctival hemorrhages, you know, allergic conjunctivitis, bacterial conjunctivitis, any sort of conjunctivitis for that matter, it is actually a non-negligible amount of patients that end up in those situations. And especially during this time, we want to try and make sure that those resources aren't being eaten up on patients that really shouldn't be in an ER situation. So I think it really becomes extremely important for us to be able to, you know, make this known that we're offering it to patients. But also on the other end of this, as we move forward in this, I think it's important for us to establish that role for two factors. One, in the factor of trying to keep, you know, we are primary care for eyes, and we should really be directing the care of these individuals who are having ocular problems. So whether that means that they're coming into the office, you know, to be seen, or they're having an emergency on a Saturday and we see them through telemedicine, we want to make sure that they're going to the right place. In many instances, you know, I've had a good friend that's in Palo Alto around Stanford area who has had, you know, a couple patients who had retinal detachments, went to the ER first. They didn't have a, you know, staff physician on there that was a ophthalmologist that was in, you know, had to wait a long period of time. Whereas when they came through him first, he directed them just directly to the, you know, to the retinal specialist for care, and was able to, you know, have those retinas treated in that period of time. So I think it's also an important thing for kind of direction of care in the future, and making sure that, you know, we are making sure that our patients get to where they need to be.
Yeah, John, one quick thing there. One of the things that we have used for a long time at state and federal advocacy levels is that optometrists play a very crucial role in unburdening emergency departments. And that's part of the reason why we were almost nationwide allowed under these shelter-in-place orders to see urgent and emergent cases, was because that was a policy point that rang true with all the regulators. The other thing is that emergency departments are not, they're not powered to see routine eye care stuff. I mean, my rule for an emergency room is if you can walk out of it, you should do it. Because, I mean, they're great places to be if you're gut shot or a bit of a car wreck, but for routine care stuff, they just do nothing but wreak havoc and delay care. So, and raise costs tremendously. So yeah. There we are.
Yep. Yeah, that was actually the initiation of a program that we'll talk about in a little bit, but that I think, and Marcus, I think, can touch on this quite a bit, being at Iowa, but the use of peer-to-peer, and you know, kind of how that can work in a emergency environment.
Yeah, so we've been doing that quite a bit, actually. There's, being in Iowa, a lot of rural areas surrounding Iowa City, where the hospital is, have little quick care clinics, or, you know, the clinics in the Walgreens or whatever. And there are some of those that are associated with the University of Iowa, despite being 30 plus minutes away. And I'll frequently get a message from a PA or a nurse practitioner with a picture of someone's eye, and they ask if I can help assess this, or if this needs to come into the hospital, things like that. So we've been doing that a lot. Got just actually on Friday, had a nice little dendrite in one of the pictures. The PA did the right thing and stained with fluorescein and said, I think this might be herpes simplex related. I've sent them to you. Call the patient if you don't want this. But I got a nice picture on my screen, and the PA was correct. And so that was a great example of peer-to-peer. One other thing that we've been doing, more scleral lens related, or just toying with actually more so, is we, at least for a couple days, we took our room that has our anterior seg OCT, and we completely just wiped everything down, made it almost like a clean room, if you will. And we had a designated technician in that room who just stayed in that room all day. And for the little more higher risk scleral lens patients, we would have them come in to that room specifically, where the technician would do the anterior segment OCT imaging of like landing zone and vault, along with a picture or a video of the patient moving their eyes around. And then they would send that to us, or we would observe it in real time, but being apart from the patient. The main advantage for that, obviously, is COVID reasons. We want to limit patient or person-to-person contact even as much as possible. But those are some other solutions, at least for this specific time in telemedicine.
Yeah, absolutely. Now, there are two questions here. One, I'm going to go ahead and just show real quick. They want to see how the Zoom works again. So essentially, the way that the Zoom works is if we go ahead and we hold this up on the iPhone, this is a 8 Plus, you'll go ahead and you see the little one time right there. You can go ahead and slide that, and that'll zoom in. So back
on some of the phones, if you just take your fingers on the screen and go like that, you'll also
expand. That'll also zoom in as well.
I can actually speak to Android there quick too if you want.
Yeah, perfect.
Android's the same way. You touch the screen, and you can see there's that little slider at the bottom. So you can do this left-handed. And you just move that slider to zoom in and out. So same exact way as the iPhone, essentially.
Perfect. Now there is a question here which says, should we recommend and teach new patients insertion and removal over video chat in cases of COVID, and request them for follow-up pictures? So Pooja, for me, when we had the whole shelter in place that was instituted in our area, which happened on March 16th, I was in the middle of about 10 new fits. And unfortunately, all of them had their lenses already. So I had to be able to accurately assess visual acuity, assess their fit, and then also help them to troubleshoot insertion and removal of the lens. Now, the nice thing was during that time, I was able to actually very successfully coach them through application and removal of the lens. It's actually quite easy during the video chat. In some cases, easier than it is in office, simply because I can have them put the phone at an angle that I'm not able to get to with my own, head next to the head. So I'm able to see, are they actually centered to the eye? Are they slightly to the side? How exactly are they doing this? Essentially, what I've had them do is lay their phone flat on the table and use their phone like a mirror. So they're looking right down at the phone to see what they're doing on the eye, but my camera is also looking right back at their eye. So I can see exactly where their centration is. So yes, so I have had to do that quite a few times. And we can talk about visual acuity in a little bit. Now, this case here is actually one of those cases. So this was an individual who I had fit with a scleral lens. You can see in the images here, not ideal images there, but we're getting an idea of how the haptic is fitting. And we can see that there's no grossly impinged blood vessels. When he's looking in the upward position, I am seeing some inferior blanching there, right? But when I have him look down into the downward position, we're not really seeing any superior blanching. And when I went ahead and saw him on the video chat, I was able to appreciate that the lens is actually a little bit loose. And what's happening is it's translating up and down. So when he's looking in the upward gaze, his upper lid is actually pressing that lens downward, which is creating that inferior impingement look there. So that's actually what's going on there. Now I'm only able to appreciate that by getting the dynamic movements that happened during the evaluation when we were having the video chat. Now, subsequently, I also had him send me a video, which of course I couldn't find, but essentially it was proving the same thing, that his lens is indeed a little bit loose. However, at this time, I didn't feel confident enough to make a change to the lens based on what I could tell from this. So I just left the lens as is and told him, I'll see him back in 6 weeks because it's not causing any harm or any issues. Now, for you guys, Clarke and Marcus, are you guys, finding the same thing, that you're having to evaluate these guys and kind of see how things are working out?
Go ahead, Marcus.
Yeah, I think exactly everything. I agree with everything you just said, John. And one key point that I just want to extra stress there is, like you said, getting the picture of this lens. You might see that blanching and think, oh man, I didn't get the fit right, But when you do the video, then you see, oh, it's not actually that I'm impinging inferiorly, it's that the lens is loose. And so having that synchronous or that video versus only the asynchronous or that picture can really tell you a little bit or a lot more information about your lens fits and just patient overall health.
Yeah, I think, the alignment of a contact lens is a geometry problem. And having a snapshot in time of a dynamic situation really fails the standard of care. Even if you're in your office, and let's say you're in your office, a patient in your office, and they take 10 photographs of the patient and then lay them out on your desk and you look at them, it's really no way to evaluate a patient's alignment. And so I think the videos are much more valuable in that regard.
Absolutely. Now let's go ahead. We're going to go on to another example here. So this is actually same patient who called me up 2 weeks later because he had slept in the lens. And he took his pictures having woken up with the lens in the eye.
They probably weren't loose at that moment.
No, they were not. So you'll go ahead and be able to appreciate that this is looking a wee bit tight there. So he also went ahead and I had him send me some lens off images as well. And you can see these images. You can see the kind of limbal hyperemia that's going on. You can see a little bit of an impression in the areas around that limbus. Overall, you can see that this is not a happy eye. So essentially, I just had him stay out of his lens. We followed up later that night just to see that, the eye was indeed better, and it was, and he was in no pain, no, light sensitivity, nothing that would caused me to bring him in, but certainly something that, you can really tell he's got a real floppy eyelid there. But you can get actually a lot out of these sorts of evaluations.
Hey, real quick question, especially on someone like this, or you mentioned you had those 10 patients in the middle of a fit when shelter in place comes in. What are your, John and Clarke's, thoughts about, I've had a lot of people ask me if I feel comfortable dispensing a lens and like a sodium fluorescein strip, have the patient do it themselves, take a picture, take a video, whatever. What are your thoughts, feelings on that?
Clarke, go ahead.
I don't have fluorescein strips in my office because I do it like this, but
is that a syringe?
Yeah, it's a syringe. I think John's doing this now, right?
Yeah, I'm doing that too.
You guys are just walking around with syringes of fluorescein?
Yeah, I'll show you how to do it sometimes. That's a talk for another day. But
okay.
Could you do that? I guess you could.
So I actually got some legal consult on that because
it's tough. Again, is that meeting the standard of care? That's the question I would say. Is it if dispensing fluorescein strips to a patient, having them self-administer that, and then viewing it, if that meets the standard of care? I guess it depends on the situation. I think in the absence of a pandemic, I would say that's failing the standard. In the presence of a pandemic, if a patient can't get to us, particularly if they're high risk, they're an older patient, they're in a nursing home or something, I don't see anything wrong with that. I think that's a prudent use of technology that's there, and I think it would be justifiable. But again, until something's tested in court, you don't know whether it's a provable standard or the evolving standard.
All right, John, tell us what the law says.
So I got a legal consult from a friend of mine that's an JD, and she was saying I would have a hard time defending that one should a patient end up creating an abrasion on their own cornea, and if the patient wanted to pursue that legally, you'd be hard pressed because you gave that patient a diagnostic tool, essentially. So we have been working on a solution for this, and hopefully I'll have something for you in the next month or so.
Is that a pun? Like you're working on a solution?
Well, we're working on something to answer this solution, but yes. But yeah, well,
I had to.
Yeah, working on a solution. Yes, but yeah, so yeah, that'll be hopefully coming here shortly. But that gets into our limitations, exactly what you were saying here, Marcus. So, certainly, we have the limitations that we're not able to get real depth. We're not able to create a slit to be able to create that ability to evaluate the depth of a tear film reservoir. We don't have cobalt blue illumination right now. We also don't have the ability to put Lysamine green on the eye. So there's all these various different limitations that are present. The nice thing about this, though, is all of them are solvable. There are apps that will allow you, and we are in a development process right now, but there are apps that allow you to change the color of the LED on the back of your phone so it can illuminate a cobalt blue light. Then people ask, okay, well, you have that. Now what do you do? How are you going to get a Ratten filter on there? Well, there are digital analytics companies that are allowing you to apply digital Ratten to it. So there are various different ways of overcoming that. And, there are solutions to these things. So, the thing that I would like to kind of, I guess, set forth here is that just because a technology may not be perfect today doesn't mean that it's not going to get better. That's always the key on this, is when you see a technology that is, and I look at this in one aspect, that, you know, if a technology is threatening, I would start embracing that technology rather than running away from it. That way you can drive the way that it's being developed, and also drive the use cases. Because what happens is, if you're not the one doing that, there are plenty of corporations with a lot of money that would happily do that for you, and then show you that you're no longer, necessary in the process.
Absolutely. I can't agree more with everything you just said. I think you're right on.
Yeah, it's a slippery slope, it is, but these limitations are something that will get solved.
Yep.
Now, to show how I capture visual acuity, this was a demonstration of our prototype of how we did visual acuity. This is a augmented reality system that essentially it will measure out exactly 10 feet for you. For those that were at Academy, they probably remember the fellows doing research project that went on, but this is exactly that system. So essentially, you're doing a visual acuity by answering questions. This was the Gen 1 prototype of it, but essentially that's how the system works. So it's able to accurately get a visual acuity there. Now, the American Academy of Ophthalmology has actually a simple solution for this, low-tech simple solution, which is to print off their sized Snellen sheet that's made for a standard size piece of paper, and then simply measure out 10 feet and stand at the 10-foot area. Now, even with that, though, you need extremely explicit directions. You need to know where the person's foot is in relationship to that line, in relationship to their eyes. There's a lot that goes into that. So
one point just to add on the AR visual acuity or the online visual acuity, there was actually just a study that came out in 2019, at the end of 2019, November, that was measuring acuity taken in office versus online. Not this specific one that you showed, but a reputable one. And they found it in patients that were refractive error between -6 and +4. It was considered non-inferior to use the web-based visual acuity in 90% of patients. They did it on 200 eyes. And that means within half a diopter of what the in-office eye care practitioner found. So that's more of reason I say that is more just if you are on the fence about whether telemedicine is coming or not, it's already here. So, and that's, like you said, technology is going to get better and better. So that's our starting point, already non-inferior.
Now, I guess the next thing on this is, to Marcus's point earlier, is the peer-to-peer on this. So I'm going to go ahead and just show a quick video here. I'm going to speed this up significantly, though, so that you can see this. Essentially, what we were doing with this was showing that we can do a peer-to-peer slit lamp evaluation of an eye. This was with Karen from Boston's site. And what we're doing with this is doing a true peer-to-peer on a scleral lens, and she's able to evaluate it in real time with me. And she's getting the exact same view that I have right here. Now we can go ahead and increase the image quality on this as well. Well, we could if I wasn't already playing it. There. No, you get the idea. So essentially that could be done at a distance. I think at this point we probably need to answer some questions and then turn it over to Clarke to run through the important part here.
The important part.
Oh
my gosh.
So, John, I think you guys did a great job at answering most of the questions as you were going along. You've got that VA one in there at the end. So we'll let Clarke get started with the billing and coding. While he's getting his slides up, I'll just share some of the places. We've got over 200 people on here from Colombia, Venezuela, Nigeria, Amsterdam, Cyprus, India. Afe's drinking a beer in Amsterdam, and Ed Bennett is jealous. So that's what we've got going on here on our end. So Clarke, I'll let you finish up, and then if there's any questions sprinkled throughout, we may interrupt, but otherwise take it away.
Feel free to ask questions in the Q&A part of the thing for either myself or for John and Marcus. I'm sure the questions are still coming. So just real quick, there's my disclosures. Everything I'm going to say here in the next 10 minutes is based on guidance that's published in the Federal Registry in 3 places. One is the most recent one, which is the promulgation of rules for what is called the 1135 waiver that allows us to use telehealth in Medicare and Medicaid programs during the public health emergency. The second one is the original rule for modernizing telehealth in communities, and this is where the CPT codes were promulgated, and then finally the HIPAA rule, which still governs everything. Now, the important thing here is that to know where we are right this minute, you have to know where we were, and because we're going to go back to where we were when this emergency is over. So in January 2013, the Office of Civil Rights, which every branch of the executive has a division of civil rights. And so for the Health and Human Services Civil Rights Division, they published a final rule for HIPAA regarding telemedicine telehealth. In 2019, the new codes were created by the Edit Committee through AMA. They were finalizing the rules in 2019, and all but 2 of the codes took effect in 2019. But there were 2 that started in January of 2020. We'll talk about that in a minute. And then in April of 2020, the House again promulgated the waiver. And there are several things that are in the waiver that I should highlight. One is that it makes most of telehealth services covered services under Medicare and Medicaid during the emergency. In normal times, that's not been the case. They have not been paid. They've been non-covered services. Now, that doesn't mean you can't bill them, but the patient has to pay them out of pocket. The other things that were done was, one, that they promulgated a fee schedule to make telehealth on par with face-to-face, so that you get paid the same thing for a telehealth visit that you get paid doing a face-to-face. The third thing was waiving the security on the rules for telehealth equipment under the HIPAA guidelines. And essentially what they've agreed to do is not enforce. They're not changing any of the rules. They're just waiving their enforcement of the platforms that you use. And then finally, the last one is they waived the established patient limitation on telehealth, because in all of the telehealth policies throughout the private carriers, and if you look at the plain language of the rules under CPT, they're all about established patients and not new patients. But under the waiver, you can see a new patient in a telehealth environment. So let's just quickly look at the codes the way they are. The first one is the only one that can be initiated by the provider. Now, you're going to see a pattern here of certain things that go into telehealth visits with regard to making them billable. The first is that, except for this check-in, they have to be initiated by the patient. If you reach out to a patient, anything other than this virtual check-in code, this HCPCS code, you cannot bill that as a visit. So it must be conducted by a physician or other qualified health professional who is allowed to report in service codes. It can only be used on an established patient. Now, again, that's waived right now, who must be given documented consent. For every telehealth visit, for you to pay it, you have to have an affirmation in your record that you ask them if it's okay if you bill that visit to Medicare or Medicaid, and they have to consent to yes. And if you don't have in your chart somewhere that you ask the question that they consented, the visit will not be paid, or it will be paid and then they'll recover it on audit. Now, one of the things that is throughout the telehealth codes is that they have a different place of service. And it's not the office-based codes that we're used to using, which is code 11. These codes are right now, their telehealth codes are telemedicine, and the place of service is 02. Now, for the pandemic waiver, you need to use code 11, because one of the ways they have used to make sure that they're not paying these codes is when you put an 02 in there, all the 02 codes are non-covered. And so rather than reprogram everything for the emergency, what they're having us use is put the 11 code in place of service when you bill these codes. Now, that matters because when I put the codes into my EHR, we put them in with the 02 because that's what we're required to do. But you have to edit each of those every time you bill one to make sure the 11 is in there or you won't get paid. It cannot originate from, now here's the other one, and Marcus, your little guy that calls you every day, this is an important one, is that, and this is true for all of these codes, they cannot originate from a related E&M visit provided in the previous 7 days, or they cannot result in an evaluation. Part of your treatment plan cannot be to see the patient in the subsequent 24 hours. So the patient that I saw where I found the ulcer, I brought her in the next day. So I couldn't bill the E&M code as a telehealth visit because part of my treatment plan was to bring them in the next day. Now that should not be a reason not to bring them in 24 hours because again, you still have to abide by the standard of care.
Hey,
now,
real quick, question on that.
Yeah.
So you're saying if you did the telehealth visit, from that visit, you can't see them within 24 hours and bill for it? Is that what you're saying?
Part of your, no, so you get to bill for the visit face-to-face, but if part of your treatment plan is to bring them in the next 24 hours, then you cannot bill for the telehealth visit the day before.
Perfect. That's what I want clarification.
So the time duration for a check-in is 5 to 10 minutes. Again, it can't be face-to-face, and all the above needs to be documented. We probably won't be using these much. I don't use them much myself right now. The next set of codes are the telephone E&M services, and there are 3 of these. There's 41, 42, and 43. And again, they all outline the same services, but for different time periods. And again, the plain text of a code rules. It's a telephone evaluation. So this is you talking to somebody on the phone and not doing a video chat because there's a different code for that. And so if somebody calls you and they initiate it, or it's a parent or guardian, they can also do it, and it's not related to a service in the previous 7 days and doesn't result in a visit the next 24 hours. If it's 5 to 10 minutes long, that's a 41. If it's 11 to 20, that's a 42. If it's 21 to 30 minutes, that's a 43. And again, everything has to be documented, including the consent to the visit being billed. Then you've got the online digital services, which is what you would use for a like a video, like a FaceTime chat, where you're looking at the patient. And again, they're the same rubric. You're using 21, 22, and 23 for 5 to 10 minutes, 11 to 20 minutes, and then 21 minutes or more. These are normally non-covered services, but they are covered right now during the COVID emergency. And again, you have to document them. You can't result from something in the previous 7 days, can't result in a visit in the next 24 hours. So you can see the pattern. It's the same for all of these as you go through the whole thing. Then you've got the non-physician codes. I put this in there as a matter of reference. None of these are payable even during the waiver, but they are something that's out there for reporting purposes only because some private carrier may elect to pay for these things. And again, all the waiver stuff applies to Medicare and Medicaid. You do have to check with your private carriers about whether or not it's a billable service or not. I've received no guidance from any of my providers or any of my payors that they're covering these services right which is interesting. I really thought they would once Medicare did what they did. Then again, this is the waiver thing. The platforms that are allowed, you can use WhatsApp, you can use Facebook Messenger, you can use Apple FaceTime, you can use Skype, Jabber, iMessenger, EHR. For some reason, I changed my letters to HER and wants to do that. Reimbursement rates will be the same as for office visits. So one of the other things I want to use here is, talk about here is another way to bill for these services is to bill E&M codes, and you use that in the same schema that you would, a regular E&M in your office, the same requirements, and then append it with the 9.5 modifier. The 9.5 is a telehealth modifier, and that, I think that makes it simple for a lot of people. Is to just use your E&M codes because you're used to billing those, and then just make sure that it's a 9.5 modifier and your place of service is 11. Because again, the change to 11 for the place of service is an expediency for the HHS, so they don't have to reprogram the whole computer system. A couple more points down here at the bottom. The general ophthalmologic codes do not qualify under the waiver. You cannot use them, so don't use them. This is all about E&M codes and the HCPCS codes if you're doing the check-in. And you can see new patients. So to wrap it up, there is a set regime for how telehealth codes get coded and billed, and we're going to go right back to that once this pandemic waiver expires. And the waiver only, again, applies to Medicare and Medicaid. Check with your private payers. In all cases, you have to document that the visit was synchronous, that it was not face-to-face, that it was consented to and patient-initiated by the patient. And the other thing that's really important is that you must meet the standard of care for these patients as though they were being seen in your office. But again, standard of care has two components. One is an adjudicated standard of care. That is, what's part of the case law that's out there. But the other is the evolving standard of care. And that evolving standard of care can take into account the exigencies of this emergency and allow the standard of care to evolve a little bit. And I would submit that in a few ways, like Marcus taking care of that patient 6 hours away, I think that that's a pretty good place where the standard of care might evolve a little bit, where you need to do something where under normal circumstances, you'd see them the next day, but in this case, you can't. A couple other things is that, see, I've covered most of this. This one's a big one. Do not document in your findings something that's impossible to ascertain by the telehealth visit. They will be auditing for this. If you start making claims in your record that you saw 200 microns of clearance or something from a straight line photograph, that's going to result in a possible denial. So be very careful about documenting findings in your chart that are impossible to get through a televisit. The last two things I'm going to say, and I'll stop, is that the AOA malpractice carrier does not exclude telehealth visits, but you should check with your carrier to make sure that you are covered, because if you do something that's not covered by your malpractice carrier, you could have extensive liability if it goes wrong. And the last thing that we've seen, and this was something I was on another Zoom call last week, where we're very concerned about a lot of the docs around the country have just turned their phones off. They're just not even answering their office phone. And that's terrible, because the doctrine of abandonment is not abrogated for your existing patients during the pandemic. You are responsible for providing care to your existing patients. If telehealth is not for you, refer them to somebody else. Don't just turn off your phone and walk away. If John's got 10 new patients out there with contact lenses on and he just turns his phone off, that is a breach of the standard of care. And with that, I'll open it up to questions. But before I go, I want to provide you with these resources. AOA The Academy of Optometry, the Academy of Ophthalmology all have great resources about the eyes and the coronavirus. Three general ones, the CDC, Johns Hopkins University, and the University of Minnesota's Center for Infectious Disease Research and Policy all have tremendous websites on general information about the pandemic and this virus in particular. So with that, thanks a lot. You can send me questions by email or we can answer them right here.
Yeah, thank you so much, everyone. And I do have a couple quick questions for you, Clarke, from some of our attendees. So Regina is wondering, she said several patients with chalazion subconch hemes and that she spoke and managed over the phone. She billed a G2012. Do you think it would be better to have billed a 99441?
Yeah, well, okay. So if, again, the plain language of a CPT code rules. So the G2012 can only be billed if the patient if the doctor calls the patient. If the patient initiates the contact, the G2012 is inappropriate and probably should be recoded and rebuilt. And again, if you want to make this simple during this pandemic, bill your normal E&M codes and append them with the 95 modifier and make sure your point of service is 11. And it's going to be almost bulletproof as long as you document that it's synchronous, that it's not face-to-face, that you have consent, and that you don't document findings that you can't otherwise see. So that's my suggestion in a nutshell.
And then I think you pretty much answered this, but we have a couple questions about those modifiers from Brian Williams and Melissa Engel. And
right.
The first is, you can see them. So yeah, when do you use the different modifiers and the differences between them?
So, okay, so 11 is not a modifier. 11 is a place of service or a POS. And basically in optometry, we have always used just the office-based POS unless you're in nursing homes and things like that. Marcus might be using a different one being in a hospital setting, but those of us that are in just general clinical practice, we're using the 11 for everything. But as telehealth becomes more and more prevalent, these two will be divided into office-based versus telehealth. Now for the pandemic, just everything's simple, just use 11. Now the modifier of 9.5 is the only time you would ever use the modifier 9.5 is if you use a general office-based E&M code that, the 992 codes that you did in a telehealth environment, you use the 9.9 or the 9.5 modifier. And right now, again, when you use the 9.5 modifier, you use the 11, but when the waivers goes away, you have to use the 02 place of service whenever you use the 9.5 modifier. But for right now, everything's 11 and you can use the 9.5 modifier. Now, if you bill one of the codes that I discussed here in this lecture, you don't need the 9.5 modifier. They are telehealth codes in and of themselves. But if you just want to make life simple, you can use the E&M codes and use the 9.5 modifier.
And then would you recommend, it looks like Karuna is saying that she already used a place of service of 02. Do you know? It's
going to get turned down because they didn't reprogram the computer system. And whenever the computer system at HHS sees an 02, it's declined as a non-covered service. So you need to refile it with an 11 place of service. Just refile the claim.
Great. I think we've already gone about 10 minutes over, but retained most of our attendees. So I do want to respect the time of our panelists. So we will close up shop now. If you do have any questions, this is going to be on our website and up. So you can just go on our website and there'll be an opportunity to email our main email with questions. And I will do my best to field them to these experts. So again, I want to thank all of you so much for coming on, and we really, really appreciate everyone for attending. And again, any questions, I'll tell you right now, you can just email vicepresident@sclerallens.org, and I'll make sure they get to where they need to go. And we'll also be sending out, Dr. Gels is going to share that form on how to tell people to take the image. So we'll share that if you've registered for this. So thank you guys again.
One quick thing, I have had some questions here about the fluorescein thing. I'll put a thing together and send it up through the Scleral Society.
Great. Thank you so much. Go ahead, John.
Oh, real quick, I'm finally reading the chat here. Somebody had asked, actually it was Rob. He was asking, what visual acuity software am I using? So the Visual Acuity software is part of iCare Live. I do have a financial disclosure for that. I co-founded the company, but that is the Visual Acuity system. And one other thing here, there was a question about telehealth, and is it can you do a comprehensive exam? No, you can't do a comprehensive exam through it. Telehealth is really limited by the equipment that you can use and what's FDA approved. So essentially everything that you're going to do is adjunctive. This will in the future be kind of hybrid clinic. You'll have what you can do in the office, and you'll adjunct that with what you can do at home in a safe, reliable, and validated way. As various home-based instruments get made and approved, they will be added to what you could do. So such as the iCare home tonometer, you can now measure IOP at home. There may be other devices that get approved for that as well. So that's what I got.
So real quick before we go, if people still want to hear, there was a question about the GT modifier. The biggest difference between GT, which is a Medicare modifier for telestuff, and the 95 is that there's a limited number of things that the 95 codes can be appended to, and the 95 codes can only be appended to office and certain other basic E&M codes, like hospitals and nursing homes and things like that. The last one is, can a provider initiate a telehealth visit covered by insurance? The answer is no. Again, the plain language of the code rules. They're all patient initiated except for the check-in code.
Great. I think if that's it, again, I'll thank our panelists, and you'll probably have some emails for me with some follow-up questions. But yeah, so round of applause for all of you guys, and thank you again for everyone who joined.
Yeah, thanks, guys.
All right, everybody. Thanks a lot. It's been fun.
Take care. Thank you.